Prof. Teh did her Bachelor of Pharmacy in Pharmacy at the University of Nottingham in 1995. She graduated in 1995 under the scholarship of JPA. She is a government scholar. And after that, she did her pupillage at the Ishtar Club. And in 1996, she did her master's in clinical pharmacy at University Science Malaysia. Upon graduation, she joined the Department of Pharmacy, University of Malaya in 1997. In 2001, she joined IMU, that is at the Bioequivalence Center as the Chief Scientific Officer. And during that time, she has already gotten her PhD from University Science Malaysia in pharmacogenomics here. And in 2003, Prof. Teh joined the Faculty of Pharmacy, UITM. Her work mostly centered around pharmacogenomics, metabolomics, whole genome sequencing, and also she did quite a number of services for the company as well for the other universities. She had published around 110 articles in Impact Factor Journal, and she is now the Deputy Director of I Promise. And she is also the co-founder of the startup company ZKZ Biotech Sdn Bhd. Without further ado, I would like to invite Professor Teh Lay Kek to give her talk.
All right, as I said earlier, you know, the topic of my talk today is the right nutrients and drugs for you, what the precision health promises. Okay, last week we heard what Prof. Zaki said or discussed about the Human Genome Project. And we know that Human Genome Project actually took 13 years to complete. They have built very good machine nowadays, whereby one single human genome actually can be completed in terms of identifying all the nucleotide changes within 2 days, 3 days. Yeah, but the first genome actually took 13 years to complete. And many databases has been already established, all right, trying to actually give us back something, all right. There's so much money being spent, what do we get? So how does knowledge on human genome actually affect the practice of medicine? Are we going to get a better medical treatment, a better health system? Are we going to change our lifestyles or nutrient intakes based on the knowledge that now we have with the human genome to allow us to live healthily and age gracefully? Yeah, aging gracefully is very important now for people that is more than 40 years old, just like me. Yeah? Okay, with the completion of Human Genome Project, one thing very sure of is that we all, each individual, have about 3 million nucleotide changes in terms of the DNA sequence, right? As what Francis Collins, the director of NIH, said, we are all at risk for something, right? We are all have genetic changes, 3 million nucleotides. And from this particular chart, right, we see that there is always an interplay between gene as well as environment in resulting in diseases. Depends on what kind of disease, for example, cystic fibrosis or Down syndrome or sickle cell disease. A lot of these causes are due to genetic defect, right? But there are another category which is complex diseases such as Alzheimer's disease that probably all of us are actually at risk of, yeah? And there is an interplay between gene and environment. Environment means the food we take, how we live, exercise, and things like that. I think you heard of, if you want to actually sort of be able to still have a good memory like Tun M, we basically just have to use our brain. Okay, I always tell my students, if they don't want to use their brain, then their brain will undergo apoptosis. So they would not be able to use their brain anymore eventually. All right, and then there's another category whereby gene only play a very small portion in causing the disease, that is called environmental disease, yeah, such as influenza, hepatitis, and lately COVID, right? COVID, with the COVID pandemic, people are sequencing COVID genome, but there will be, you know, some individual that are at higher risk of getting this COVID, that is due to the underlying genetics defect that they have. Yeah. So with this problem, we are all at risk of something. How do we resolve the challenges? I think the answer lies with precision health, right? Whereby precision health takes into account differences in people's gene, environment, and lifestyles, and formulate treatment and prevention and strategies based on patients' unique background and condition, right? Okay, looking at this graph, we can see that, okay, in terms of populations, a majority are actually healthy, right? There will be a small portion of the population who are unhealthy, they are sick, right? And this is where the pharma industry targeting in designing drugs, developing drugs, and, you know, selling drugs to help to actually treat them. But if I'm in industry, you know, food industry, for example, nutrients industry, for example, we can work with the bigger populations, and of course the market value is bigger, right? Because we want to make sure everybody get the correct food, all right, and be healthy, and so on and so forth. But now, because with the knowledge of human genome, we should be able to tailor food and nutrients based on the genetic background of the people. When people are sick, all right, the cost and burden of disease basically increase. Okay, now a lot of time our healthcare system focusing in treatment, and you can see the cost for treatment is very high as compared to if, you know, we all know now, we all have baseline risk, we all have genetic variation. So at this baseline risk whereby our disease burden is still low, so if we already start to practice healthy lifestyle, correct nutrients intake and things like that, then we hope that we will delay the onset of we require treatment, yeah, and that basically will be good for the economy of the country. Yeah? We will not spend so much money on treatment and cost for medicine. So basically, this is what precision health is all about. It's not only benefiting an individual, but I believe it's going to benefit the whole nation if our nation actually strategize in adopting precision health. Okay, this is basically precision health model that I think it should be practiced. All right. So the key here is incorporating genotyping tests into understanding each of us better, right? So the medical doctors, nurses, dietitian, pharmacists, for example, they can order a genetic test, okay, to help. For example, dietitian may help us to actually identify the right nutrients for us so that we maintain as a healthy individuals. But when if we are unfortunate, we have to go to the stage of being sick, then we want a right diagnosis, correct diagnosis at the right time, promptly, for the doctor to know exactly what kind of disease we have, and then for us to be given the correct or right drugs. Yeah, and this genotyping test actually will allow the doctor to do that. Of course, genotyping test without phenotyping test would be sort of handicapped as well. So the doctors will also still need a huge medical database, for example, medical history, biochemistry test, ECG scan, physical examination, family history, to have a complete, comprehensive, and holistic information about the patients. Then believe that precision health can actually come into play by providing the best care for each individual patients to avoid serious side effects from medications, detect disease mutations, changes in genes that cause disease in patients, identify genetic risk factors to guide lifestyle, environmental recommendation that can improve the health of each patient. So this slide basically tells us something new or something old. What it's trying to say is actually the practice of preventing somebody from being really sick has been practiced a long time ago. All right, the right treatment for the right patients at the right time has been practiced for long time ago. Okay, for example, in this particular case, Pythagoras actually is a mathematician, but he suffered depression due to some what do you call that? His discovery about some mathematical equation. Hippocrates basically treated Pythagoras, but you see his treatment is changing the dietary habits of Pythagoras. Okay, and he asked Pythagoras to actually have a temporary state of abstinence, and he helped to detox this mathematician. With that, actually, this mathematician become better. So what he means to say is, before somebody become really sick that require a drug, probably the practice of changing diets as well as lifestyle change, will be important strategies to start with. And this is basically, today we call it nutrigenetic or nutrigenomics. Yeah, with the completion of human genome, we were able to actually use the genetic information to help to actually give the correct nutrients to each individual to prevent sickness. Okay, personalized nutrients and drugs. All right, let food be Thai medicine and let Thai medicine be food, yeah, according to Hippocrates. So with regards to nutrients interaction with genes, basically there are two components. We call it nutrigenomics or nutrigenetics. All right, so nutrigenomics is a bigger component which investigate complex gene nutrients interaction on genome level, whereas nutrigenetics investigate interaction with genetic background. Okay, but however it is, both of these nutrigenetic and nutrigenomics aim to actually use personalized diet to prevent or delay the onset of disease and optimize and maintain human health, right? Okay, and what is pharmacogenomics? Actually, pharmaco or pharma means drug or medicine, and genomics basically is the study of genes. Yeah, so pharmacogenomics basically aim to personalize medicine, tailor to each of everyone's genes. Yeah, so that we can actually give the right patients the correct drugs. Okay, these are some evidences that nutrients has interacted with genes to produce the phenotypes. Yeah. Okay, looking at these two mice. Yeah. Okay, we have one big fat yellow mice as well as this dark color fur mice, which is a normal one. Yeah. So these are actually the offspring of a pregnant mother of these mice. Okay, when pregnant, the mom was actually given bisphenol A, but they were given different diet as well. Okay, so for this big fat yellow mice, the mother was given normal mouse diet, whereas for this mice, actually this mouse, sorry, the mother was given supplements of choline, folic acid, betaine, and vitamin B12. Yeah, but both of the mother actually also were exposed to bisphenol A. So what we can see is from this particular study, the offspring which is yellow and fat, okay, they are actually at high risk of cancers, diabetes, and obesity, right? And also have a reduced lifespan, right? Whereas these dark color fur mice, they have lower risk of cancer, diabetes, and obesity. So they are normal. So what happens with food that we take in changing the risk that these two mice had is because nutrients from our food, right? They are usually channeled involved in biochemical pathway that actually extract methyl group from the chemical compounds that we eat. For example, folic acid, they extract the methyl group. Methyl group basically is a CH3 group, and then what they do is they will attach this methyl group onto our double-stranded DNA. What will happen next is this DNA probably will not be able to be expressed properly. Yeah, so methylations of this gene all right, actually cause inhibition of expression of certain genes. Right? If the genes are good genes, for example, that genes that protect us from getting cancer, then inhibition of expression of this gene will cause somebody to get cancer. So that is how it's important, you know, the food that we take, for example, betaine, choline, B vitamins, methionine, you know, those amino acids that we take can actually affect diseases that we're going to have. Even though we may not be born with genetic defect to have cancers, but if we have not been taking the correct nutrients, then subsequently, because of the food that we take, we may get cancer also. So how does this nutrients actually work in changing the expression of the gene? Basically, for example, fat may sit on this receptor called PIPA alpha, whereas vitamin may sit on a receptor called RXR. And they will actually, by sitting there, they will change the expression of the gene. Okay, and that will influence protein synthesis as well as metabolite production as well. Okay, these are some of the other ways that the mechanism by which nutrients influence gene expression. Okay, looking at this particular chart on the left, okay, we can see bioactive food compounds, they may act on the regulatory sequence in DNA. Regulatory sequence in the DNA basically will regulate the functions or expression of the gene, in short, yeah, in simplified kind of words. So they may actually change the promoter, the function of the promoter region of the gene and cause different kind of proteins or different proteins being produced. Because different proteins are produced, then we will behave differently. Okay, the nutrients that we take or the bioactive compound that we take may also actually, you know, stop transcription or make transcription possible by actually switching on and switching on certain gene through methylations of the cytosine or acetylate histone, you know, of this particular process. Yeah, then the DNA cannot be transcribed. Then when the DNA cannot be transcribed, then there will not be actually production of mRNA, and no mRNA to be translated to protein, then we will have malfunction protein or no protein being produced. All right. And these are some of the transcription factor pathway that mediate nutrient gene interaction. What it means is, for example, fats, right? Through the compounds, fatty acid or cholesterol, they may interact with all these transcription factors like PIPA, SREBPs, LXR, and so on and so forth to actually affect the function of all these receptors. Carbohydrate with the molecules of glucose, they may also act on USF and the other receptors. Proteins, yeah, and vitamins as well. Vitamin D, for example, will sit on vitamin D receptors and affect the expression or the function of this particular receptors, and so on and so forth. Yeah, even herbal products. Yeah, a lot of herbal products contain flavonoids. Yeah, so these flavonoids may actually act on estrogen receptors or NFKB receptors or AP1 receptors, so on and so forth. So the herbs that we take every day may also actually affect our health. That is how it works. Okay. One more mechanisms that nutrients may influence, may affect us is through prevention or causing DNA damage. For example, I mean, this is free radicals. Yeah, this one on the very left is basically free radicals formed due to oxidative stress, calorie excess. That's why nowadays people are saying that there are already many studies that prove that fasting is good. Yeah, even though fasting has been known to be good, for a long time as a Muslim, right? But nowadays people have provided a lot of evidence to say that people need to fast because fasting is good. So calorie excess actually may actually produce radicals that actually damage our DNA. Yeah, when our DNA are damaged, then of course our cell will die, right? And then that will cause aging and things like that. Yeah. All right. So after going through some of the mechanism that I have bored you, perhaps. All right. So I just want to give you an example of soya bean, right? Soya derived kind of food. I think a lot of us take soya-based food, tofu, soya milk, and so on and so forth. A lot of beans and things like that. But just for your information, all this soya bean stuff actually may contain chemical compound that is called genistein, dexane, and so on and so forth, that they may bind to estrogen receptors, alpha and beta. ER stands for estrogen receptors. That sounds very familiar for the woman, especially estrogen. All right. So what they do subsequently when they bind to these estrogen receptors is they will modulate cell proliferation, their growth, as well as differentiations. And they may also act as an antioxidant or anti-angiogenic molecule. They have been claimed actually to reduce risk for hormone-related cancers such as breast cancer, uterine cancer, and prostate cancer. So all the men will say, I will take soybean after this, right? Because since it can actually reduce risk of prostate cancer. But wait, hold on, yeah. You may need to get your gene checked before you start consuming a lot of this soya milk or soybean stuff, you know, with the aim to actually protect prostate cancer. Because why? Okay, yes, these studies, two studies that has been published in 2009 that say people with different kind of estrogen receptors polymorphism are at different risk of getting prostate cancer when they consume soya. Okay, for example, if somebody have a genetic variation that we call it 192G to C, okay, in exon 1 of estrogen receptor alpha, this subject actually have an increased chances of getting prostate cancer, right? But if somehow somebody have a genetic variance of this particular receptor type, estrogen receptor beta, okay, if the person have a genotype of TC or CC, then the chances of getting prostate cancer will decrease if he consumed phytoestrogen kind of food. So does it mean that you will want your gene tested before you actually take soybean, right? So there are so many food actually. All the food actually bind to certain receptors of our body. That's why, you know, understanding what we have as in our whole genome will allow us to personalize our diets as well as our medicine better. Okay, and then this table is a list. My mic wasn't working. Hello, can you hear me? All right, sorry. There was just a pop-up to say the mic was not working. I'm sorry again. All right, sorry. Okay. Okay. So there are several diseases that are due to genetic defect. For example, lactose persistence. Okay, that actually cause somebody to have diarrhea or vomiting, can be due to genetic defect in one of the gene that is called MCM6. So in order to tackle this problem, somebody will have to go for lactose-free diet, right? And galactosemia, you know, somebody will be lethargia. Lethargia means always feel very tired. He may also have yellow skin, and then sepsis is basically infections. Okay, so he may actually have genetic defect along the pathway that are involved in galactose metabolisms, and the gene involved could be GALE, GALK1, or GALT. And then this person, if identified so, all right, should have a galactose-free diet. But the thing is, how do we know we are galactosemia? We will only have symptoms such as lethargic. Everybody feel lethargic in the morning, especially Monday morning. Probably yellow skin, but a lot of us also say that we are yellowish anyway, right? And then sepsis for probably indications of the person will be at risk of infections. But that again will not allow us to know that the person have galactosemia unless somebody really go and look at galactose metabolism of the particular individual and identify this person actually have galactosemia. All right. Or if we have a genetic test that can identify mutations or genetic variations underlying these three genes, then we can already and if the person really have mutation of for these 3 genes, then this person have galactosemia. So now we can see how genetics has been linked to a lot of this metabolism, have been linked to a lot of these diseases. So by knowing the genetic of each individual will allow us to know ourselves better, then we can tackle it better. Because it's very difficult to go on galactose-free diet, right? So I hope that by now you can actually see you know, how wonderful is understanding genetic actually will help us to live a better life, right? For example, gluten intolerance. Actually, there are many of us that are actually have gluten intolerance, right? And so far in our lab, we have developed this test. We have actually developed a test that identifies 6 different variations, right? That can increase the risk of somebody getting symptoms such as stomach ache, stomach pain, joint pain, inflammation, basically constipation, nausea, vomiting, rashes, if they consume gluten, because they are gluten sensitive. They are intolerant to gluten. And a lot of our food basically contain gluten, right? So we also have a friend that have gluten sensitivity, and when we tested her gene, we found that she had a high risk of getting gluten sensitivity. Then we advised her to actually try to cut down gluten, and after she had done that, she actually you know, get her rashes reduced, and she was so thankful that a problem to her that has existed with her for 30 years has resolved. Okay, vitamin D. Okay, vitamin D receptors polymorphism or variations has also been linked to breast cancer risk. All right. For example, low expression of this particular gene, vitamin D receptor gene, may be associated with increased breast cancer susceptibility. Right. So the intake of vitamin D may be increased in these patients in order to prevent or reduce the risk. So there are all these informations that are important to help somebody to prevent risk of certain diseases if we know better ourselves. So I think I have given you some example of how understanding our genetic variations can help us to actually know exactly what type of diet that we can take, so that we can actually, you know, reduce problems such as, from a very big problem of having cancer to actually rashes, right? So the next is, unfortunate if we already have disease and we have to be treated. This is where pharmacogenomics have to come in, right? But by definition, pharmacogenomics basically study the role of genome in drug response, right? So it is very useful for us or for the doctors or pharmacists to know or to predict somebody's or the patient's response based on the genetic background, so that we can identify who will respond to drug A and who will not respond to drug A, and so that we can actually give the correct drugs to the patients. And that is called tailoring therapy. Tailor, just like tailoring your clothes, making clothes by the tailor. So now we can actually tailor medicine for you based on the genetic background. Okay. Unfortunately, I would like to say that, you know, there's a lot of try error in the current medical practice, yeah, and that's why we said that, you know, medical practice without genetic information may involve a lot of try error. I don't like to say this, but I have to say this because some medical doctors may not like it. I'm sorry, but the truth is, yes, there is a lot of try error in actually the doctors giving medicine to us. Yeah, and a lot of time when we go and see a GP, the GP will actually diagnose us based on our presentation, our signs and symptoms, and they will always give us a standard dose of a drug, you know, or 3 or 4 drugs to treat this particular disease, and everybody basically get about the same drugs. Yeah, and that is basically what we mean by try and error and not personalizing the drug for us, because the drug that is given to us is just based on sign and symptom. It's not specific and it's not selective. Yeah, it does not evaluate the therapy, the different therapeutic response that the doctor may see from the individual patient. And basically that is also called the blockbusters concept, because when the pharma actually develop a drug, right, they want to develop a drug that hit the biggest market, you know. So everybody, for example, have hypertension, then they will just give drug A that treat hypertension, and they hope that that drug can treat everybody with hypertension. That is called blockbuster. Okay, so as we say here, I put here comparison of current medical practice, personalized medicine, and precision medicine. So it's up to you now to actually see which one we should actually adopt in terms of medical practice. All right. So currently, the medical practice involve using vital sign. Vital sign is the sign that the doctor can observe, right? Or they can check, for example, BP, blood pressure. All right. Those are vital signs, yeah. And they will use our vital sign to actually check us, fever, yeah, temperature, and things like that. And they will use their expert background, experience, and judgment to actually assess our symptoms and do judgment and to make diagnosis and to actually give us medicine. That's why we always say, doktor tu tak bagus, you pergi doktor lain lah, doktor lain tu bagus sikit. So there are things like that because the cure rate actually depends on the experience of the doctor. That's why we pay more for a physician rather than just a GP. I'm sorry if I teguris hati some people. Okay, then we actually look at personalized medicine. So personalized medicine basically collect and analyze extensive information about patients, but the difference between current medical practice and personalized medicine is they use genome information. The physician use the genomic information and data to make the diagnostic treatment better. Okay, then they can stratify disease better, they can select medication better, they provide a therapy to initiate a preventative measure that is suited to the patients at the time of administration based on the gene of the patients. All right, so what is different between precision health, precision medicine and personalized medicine? We can see here, precision medicine actually use massive data network. All right, so now in order to treat the patients in front of the doctor, now the doctor not only use the information of these particular patients, but he also use information from big database, right? There are big database that has been created in the scientific community to say that 10,000 of people with this particular sign and symptoms, they actually respond with this particular drug. Okay, and this patient has this particular genetic background. So that is what precision medicine is. So I believe it's very clear precision medicine would be better than current medical practice in a more targeted therapy to allow us to actually recover faster, hopefully, inshallah. Okay, so what is the percentage of drug response so far that we observe? Yeah, for example, if somebody have asthma and he or she is given beta agonist, actually the rate of poor response, that means that patients do not respond, is varies from 40 to 75%. What it means is perhaps only 25% of the people are giving a good effect that we want to see. All right, hypertension, 70% of the people may respond, whereas 30% do not respond. Solid cancer, only 30% of the people will respond, whereas 70% of the patients do not respond. Same as diabetes, probably using sulfonylurea, the drugs that a lot of this to treat diabetes, probably only half of these patients will respond. So you see, the drugs currently used and has been marketed to treat us only treat a minority of us. Yeah, of course, it depends on what disease. Not only patients don't respond, but you know, the drug, if it's not given to us correctly, or if we are not suitable to take the drug, it will cause adverse reactions. For example, in US, you know, adverse drug reaction actually accounted for 2.2 million hospitalization. And it caused like 100,000 deaths in US every year. Right, in Malaysia I do not know because I do not have the data. Okay, so the phenomenon of one size fits all basically cannot be used anymore. One size fits all meaning that one same medicine, A, B, C, D, E, F, G until Z person can use. No, we are all different. Remember, we are all different by 3 million nucleotides. All right, we are a unique entity. We have to be dosed correctly. We have to be given the correct drugs. Yeah. All right. So I think this one has been said earlier. So most drugs are not or partially effective only in the market. All right. So probably only half of us are benefiting from the drugs that we use. Scary, isn't it? Another 50% are just taking drug every day, but they are not recovering. They are not getting any benefit of it. All right. I'm scaring people, right? Because okay, so from this pharmacogenomics aspect, so we can see that currently, if we don't use pharmacogenomic approach, what happen will be this pool of people in A, in the chart A, this pool of people, all right, they will be given one drug A, and then we will wait and see who will respond. Oh, good response. The orange people get good response. The green people, no response. Okay, fine. And then the blue people actually get adverse effect. Adverse effect, just to get some rashes is fine, but some of this adverse effect actually cause death, right? But if we have pharmacogenomic in place in our medical practice, what will happen is this pool of people, before any drug is given, we will do a pharmacogenetic test. Right. Then from this pharmacogenetic test, we're going to subgroup these patients into different groups. We already can predict, right, what kind of drug they can use, whether they can use the standard dose, 100 milligram, or they should be given higher dose, or they should not be given this particular drug A because they have risk of adverse drug reaction. So the orange people was predicted to actually will be okay to produce good response if they are given standard dose. All right, and so happened, yes, yeah. And the green people, basically they need dose adjustment, right? They may need a higher dose because they metabolize the drug so fast that the standard dose of 100 milligram is just not sufficient. So they need a dose adjustment. Yeah? Then they will get good response. And then this group of people with adverse reactions basically should not be given drug A, but alternative drug should be given. Okay, so this slide basically I just wanted to explain why are we saying that you need to test my gene so that you can give you can know how which drug to give me. Okay, the concept of drug reactions or action of drug is that for example, this is a drug or even nutrients for the matter. Okay, they always have to sit with the receptors or interact with the receptors in our body to take effect. Okay, and this drug have certain structural molecules, 3D structure. Same as our receptor, they have certain 3D structure because they are protein. So in order to have effect, the drug or nutrients or molecule must bind with these receptors to actually have effect. All right. So what happened will be, for example, this is a normal individual with normal genetic background. Okay, the shape of this receptor is a V to accept a drug with a V shape. All right, then they have effect. But somehow, if somebody have a mutation of these receptors, now the receptors do not actually have the V shape, but rather is a round shape. Okay, so the drug that was given to the patients, V-shaped drug, would not actually bind with these patients with abnormal DNA, resulting in no effect. But on the other hand, okay, some other molecules or whatever inside the patient's body, for example, the round-shaped molecules will bind with these receptors, and not only not having effect, but probably patient may suffer other effects. So that is what it means by, if we know what kind of receptors we have, then we can actually know whether or not we're going to get effect or not. And of course, the shape of these receptors will depend on the gene that we have. So that is how we're going to predict. All right. So in terms of pharmacogenomics, we usually say that there will be pharmacokinetics and pharmacodynamic variations. Yeah, because all these are genetic variations. Okay, for example, okay, this is basically a plot of concentration of drugs given to the patients over time, and this is basically the active metabolite. Okay, the accumulations of active metabolite over times. I think I have to rush a bit because time is running, right? All right. So, for example, what happened with this particular case is the patients, okay, the drug here is called primaquine that is used to treat malaria, right? And actually, primaquine is required to be converted by an enzyme to active metabolite. So if somebody don't have this enzyme called CYP2D6 to convert primaquine to active metabolite, then what happened is that, you see, the patients will not actually achieve therapeutic effect. Because not achieving therapeutic effect, then the patients will not recover. Right? Patient will have relapse, in, for example, in this case, right? So by testing the genetic background of the people, all right, we can predict already whether people, the patients will get benefit or not. See, this is one of the enzymes that are involved in drug metabolism, CYP450. There are a huge lot of it. That means we have to develop tests for all these members. Yeah? And then it's hoped that not only in the hospital that we can use pharmacogenomics, but in transforming community pharmacies, I believe that, you know, next is the doctors, the pharmacists at the counter will also have to know what pharmacogenomics is about, because patient will come to the pharmacist and say that I have this DNA report, okay? Doctor, give me nortriptyline, a drug that has been given to treat my psychiatric problem. But now I have this box that have bitten me and it caused me a lot of itchiness, and I want some Piriton, because Piriton is an over-counter medicine pharmacists can sell, right? So should the pharmacist just give Piriton to the patients, right? The answer is no, because what happened is nortriptyline is actually metabolized by CYP2D6, and at the same time of metabolizing CYP2D6, it also inhibits CYP2D6. All right. So, and Piriton also is an inhibitor of CYP2D6. So, concurrent use actually will cause the patients to have a higher level of nortriptyline and causing the patients to have side effects of due to nortriptyline. Okay. There are already many drugs listed by FDA that require pharmacogenetic testing before actually prescribing it, and there's a whole lot of them. Yeah, you can always go to FDA website to look at pharmacogenomic biomarker. Actually, I wanted to share some of the other story that we have in on research that we have done, but I have to run a bit fast. Basically, this is on tamoxifen. Tamoxifen is basically used to treat breast cancer to prevent relapse. So patients with certain genotype of CYP2D6 will have relapse faster compared to patients who are actually normal. Yeah. So this is just basically to tell you that genotypes will allow us to predict medicine. And CYP2D6 distribution in our healthy population, you can see that this is actually poor metabolizer. That means the Indian friends in our country will have a higher percentage of poor metabolizer. Yeah? And 40 to 50% of our Malays and Chinese friends actually are going have mutations that cause them to be intermediate metabolizer. So depending on the drug that is used, the patients may not metabolize it that well. Yeah, that will cause them to have adverse effect also. So this is a study conducted by our group, whereby we were looking at the genotypes of two genes, CYP2D6 and MDR, and we saw that patients with this CYP2D6 causing them to have intermediate mutations actually have 13-fold higher odds ratio in getting relapse. Okay, so this is what we have. And we also have a case study before done whereby a doctor in Seremban actually asked us to genotype one of the patients, because the patient was given many antipsychotic drugs, but he doesn't actually seems to recover. So the doctor suspect that probably there is some actually genetic problem with the patients that cause the use of medicine inappropriate in them. So when we tested these patients, it was true that we found these patients to actually you cannot see my slide. You can see my slide. Yeah? And you found that this patient actually have many copies of this gene. So when doctor give drug A to these patients, and the patients have an increased amount of enzymes due to duplicated genes in these patients, then the enzyme is too much, drug is too little. it has been metabolized, so the patients actually do not reach the therapeutic effect. Okay. And this is another study whereby we look at warfarin use in Malaysia, and we found that patients, again, with a genotype of CYP2C9*1*3 happen to have a higher percentage, 15.3% of 15.4% of cases of life-threatening event actually come from patients with this particular genotype. And because of this, actually, we developed an algorithm, okay, to actually predict dose of warfarin required by the patients by incorporating different genotypes, for example, the VCO genotype as well as CYP2C9 genotype of the patients. And this particular formula allows us to predict the dose required of warfarin dose required by the patients to an R-squared of 36.5%, basically more than 70% accuracy. Okay, this is another chart saying that CYP2C9 is basically related to the bleeding event. And also there are genotypes that actually, actually affect whether or not people should be put on warfarin because they may be warfarin resistant. Yeah. So VCO is vitamin K receptors gene. They actually have certain mutations that cause some patients resistance to warfarin. And we also have done a study on patients with colorectal cancer patients using 5-FU, 5-fluorouracil. And from here, we can see again, patient with homozygous mutant of this, the one of the gene called DPYD. Okay, the level of these patients were actually higher in patients with mutated genotype, causing them to actually have a higher risk of adverse effect. All right, and we further look into another group of patients that was having myocardial infarction, and they were given aspirin. And from this study, we look into the likelihood of patients actually suffer from gastritis due to aspirin. Yeah, so we found that patients with certain genetic variants, we call it UGT1A6 or CYP2C9, are at increased risk of aspirin-induced gastritis also. So what we did is we developed PCR methods, then we actually validate the method using sequencing, and then we found that, patients with certain genotype, for example, this CYP2C9*3, patients with this particular genotype have 6.8-fold increase of odds ratio in getting gastritis. Okay, we have another example that we did in HKL as well, using carbamazepine. Okay, we test patients on HLA-B1502, and we found that those patients with positive of HLA-1502, they have a high incidence of SJS as well as TEN. SJS and TEN are basically skin reactions that are very severe, as shown here. Okay, SJS basically means that there are about 10% involvement of skin reactions of the whole body, whereas if the involvement of the reaction, the involvement of the body surface is more than 10% up to 30%, then it's called TEN. All right. So we further actually look into, beside carbamazepine, carbamazepine is an old drug. Probably people are not really using it anymore. But what other drugs actually may, again, affect people with these particular genotypes? Yeah. What it means is that what other drugs that these people with this particular genotype should not take. So there's a whole series of it that we actually do modeling. So there are phenobarb, phenytoin, primidone, sodium valproate, all these drugs, lamotrigine, that this patient again will be at a higher risk if they were given. All right. So I have another case study whereby actually we use genetic testing to actually help the doctor to actually switch patients from hypertensive drug called irbesartan, all right, the losartan group of drugs, antihypertensive, to just ACE inhibitor, and the BP of the patient was controlled. Yeah. So pharmacogenetic tests actually help. And then we have this particular request from our medical doctors in Sungai Buloh last month, yeah, whereby these patients actually was developed stent thrombosis. Basically, what it means that the patients have clot, all right, or the blood vessels actually sort of blocked, and then the doctor did a stenting, And after they do a stenting, they put the patients on a couple of drugs. One of it is called clopidogrel or Plavix. And somehow, after 1 week, they found that the stent actually got thrombosed, got clogged again. So the doctor suspect clopidogrel was not working. So they actually requested a test to be done at IPOMIS to see, is it true there are some mutations? So we found that these patients are actually having a mutations that cause him to have an intermediate metabolizer. The patients from the genotype test, we found that the patient have CYP2C9 star 2 stroke star 17, and he is being classified as intermediate metabolizer. And according to Clinical Pharmacogenetic Implementation Consortium, these patients should be given alternative antiplatelet therapy. All right. But if this drug is not available, a higher dose of clopidogrel is required to actually help these patients. And basically, we managed to help the doctor to identify the cause. There is also another requirement from a medical, actually doctor from UMMC. Yeah, basically there was an email given to us to say that this particular boy, 2-year-old boy, actually have recurrent VVX infection. So they want to know why, and we found out that these patients basically have intermediate metabolism again. Looking at the graph earlier, you can see that people with intermediate metabolizer were probably not reaching the what they call that therapeutic level, as I have shown just now in this particular never mind. I have to rush. Actually, there was a slide earlier that I showed that. Okay, so I think this is probably my last slide. So from all this example, I think I would say that moving forward, precision health, all right, and the future is now. Okay, we should have our genetic test being done not when we are old at my age, but rather when we are first born. All right. So when a baby is first born, then a genetic test should be done on him, or the whole genome, or even the array SNP identification should be done on these patients, and this particular information of him should be cataloged into a chip or whatsoever. So, and then this chip basically will carry all the information about this particular individual, right? Okay, so this is basically some of the, we actually, Prozaki said earlier, we have actually conduct this kind of test in our lab through our startup company, ZEasy. And we have actually touched several aspects, including diet, weight management, that we can do through understanding our genome better, allergies, personalities, and things like that. So this is one example, for example, how genetic variants can actually tell us that we will benefit, okay, by increasing our weight loss if we undertake certain type of food, right? Having certain genetic variations, for example here, okay, if you have these particular variations and you have this particular genotype, okay, there will be an increased benefit of restricting low-fat diet, and we will be a better candidate to lose weight, and so on and so forth. So all these informations can be found in our gene. Okay. With that, thank you very much for your participations, and I think actually there are a lot more examples, but I have to sort of finish as it here. Next time, maybe we can share more. Or if you have any particular questions or any particular interest, you can always actually email us. All right. Okay, there are some questions here. For example, I would like to answer from Amalia. Do we just go to the public hospital and ask for a genotype check? Is this being practiced in Malaysia now? The answer is, I would say no. All right, because what happened is this genetic approach in as an overall treatment strategy is not really practiced. Of course, certain clinic or certain doctors actually use genetic tests, do order genetic tests for some patients in making diagnosis. For example, you know, certain cancers are basically due to certain genetic mutations. Then in order to confirm, the doctor may make a special request for DNA check to be done, yeah, but it's not done on everybody, yeah, for a preventive or for a healthy well-being strategy. And not all hospitals actually have that kind of test being offered. I mean, for example, the test that I show you on HLA-B, okay, somebody with HLA-B positive, they will be at an increased risk of 600-fold, okay, of getting very serious adverse drug reactions. But so far, we have receiving sort of requests from some private hospital, yeah, to do such testing. Government hospital, we do get, but usually we have to give them free of charge. Yeah, we just want to share our service. Okay, so I think I would say that currently we are ready to actually do genetic tests, right? But the question is always like on money, funding availability from the government, hospitals, and so on and so forth to actually make this kind of test available, right? But I believe hopefully one day it can be covered by insurance, because currently insurance is also not covering, so that actually add up another hiccup for us. Yeah, we hope that we can do something, right?
Western countries.
But in Western country, this precision health or genetic based kind of is likely because a lot of them buy insurance and is covered by insurance. Yeah, so that's why it is possible. Any other question? How reliable is the off-the-shelf product from a company like this? Okay, I think Dr. Lee. Okay, last week I did talk about DNA testing from this kind of company. They call it direct to customer service. All right. Actually, the truth is these services are not regulated by our government. Currently, there is no regulations to say that how accurate they have to provide services. Yeah. So, and I even see some of these services being offered at Lazada and Shopee. Okay, but okay, if they use a standard test, for example, you know, an array or sequencing, all right, sequencing the accuracy is 99%, same as for array. Yeah, the platform is pretty stable. The questions lies with the interpretation. How good is the database currently available to actually correlate your genotype with the predicted risk that you may have, right? And of course, you may want to see the lab, whether they do QC tests or not on the results that they provide you. Yeah, but again, I would like to remind everybody here, genetic test is a predictive test. It's not 100%, right? Because as we say, a lot of these diseases is an interplay between environment factors, lifestyles, as well as genetics. Okay. So if I'm tested to get cancers, for example, cancers that I can reduce, lung cancers, for example. And if I smoke, of course, my risk of getting lung cancer will further increase, right? But if that cancer is really due to lung smokes, then if I reduce or I get rid of smoking from me, then perhaps I can reduce my risk of getting lung cancer. Yeah. But of course, knowing that I have risk of lung cancer, I will make sure that if I have cough, I have a persistent cough with not because of flu or anything like that, I will go to the doctor and say I want a proper scan to be done. Right, then that will help us to actually identify the disease state at an earlier phase. So that is how the genetic test should help us. Okay, another question is, if this test is open to all, how much would it cost? Okay, that will depend on which platform that we want the test to be done. As I mentioned in earlier talk, we have many different types of actually platform. One is whole genome sequencing, whereby all the 6 billion nucleotides are identified, yeah, in your genome. And that actually, they don't identify it one time, they identify it many times, at least 30 times. And that actually costs 12 to 15,000 per test report. Okay. Then we also have exome sequencing kind of platform, whereby we only identify nucleotide in the exome. So in our in our genetic makeup, basically exon is the one that will be translated to protein. All right. So a lot of people believe that by knowing your exon, we will be able to actually know the proteins malfunction that we're going to have in our body, so that is sufficient to predict diseases. That exon sequencing will cost probably 3.5K. Then we have this SNP array kind of platform whereby they've already put on the chip, okay, 500,000 different probes, for example, for 500,000 genetic variation, or 660,000, or 1 million, or 1.5 million SNPs. Yeah. Then this, when your DNA sample is run on the chip, then it can allow us to know all your 660,000 variations that you have. That test, I think currently will cost from 1.5 to 2.5 thousand. Okay. Then of course we have targeted PCR approach tests, whereby if we are very sure we only want to check on one particular problems and we know one gene is affected, then very targeted, then probably the test can cost a few hundred. For example, if you want to check on HLA-B gene, whether or not we are suitable to take carbamazepine, that test costs only about 250 ringgit. Okay, hopefully I answer your question. One more question. How about traditional medicine, honey, apple cider, ginger, etc.? Yes, actually, in I Promise, we have been dreaming, to set up database, a catalog of all the ingredients of these herbal products, and then we want to actually do modeling to see all these active ingredients will actually interact with what receptors in our body. Okay, for example, honey have certain active ingredient. Okay, all these certain ingredient are of certain 3D structure. They are molecules, so they will certainly bind with certain receptors in our body. And if our body, if that binding of that particular receptor is good to produce good effect for our well-being, then we will be good. But there may be some of us that have mutation over that receptor, so the active ingredient of the honey will not be able to bind with that good receptors, and so by eating honey, the person would actually have no effect. Yeah. So any chemical compounds, be it from the environment, from the food we take, herbals, if they interact with our body, something will happen. But if we have mutations, the interaction doesn't happen, it will not happen. Yeah. So I hope that will answer doctor's questions. Okay, some wants to have the slide. Okay, I will share the slide. I think that's all, yeah, for this particular session. Okay, thank you very much, everybody. Thank you for your attention. Bye. I finished another on my job.
Thank you, Prof, for the interesting talk. Yeah, to the audience, thank you so much for joining us. Just like to remind you, there will be a few more talks by fellows of I Promise, and those new things that are being done in our lab. And I hope that you will enjoy, and please join us in the next webinar. That's what we are doing. We have to those that has approached us, yeah, either from overseas or local, that want their genome tissue sequence. We have done that, and we keep on updating. We keep on updating the information whenever there is a new info on the person. As the Prof mentioned, and also in my talk previously, the gene do not change. Yeah. So, but there are a lot more information that we still don't know. Okay, about us. People around the world are working around the clock, and so are we. Yes. We will come up with a package. We'll come up with the package, and probably you are trying to work with UITM hospital. Yeah, we have discussed with the hospital director about having this health center. They have the health center, of course, but then we would like to provide this genetic information, genomic information, and hopefully that will be very useful, not only for the staff or students of UITM, but also for the people of Malaysia. In fact, we are coming up with a working paper which actually, the working paper has been done, and we are going to give to the government, just like the other countries have done, yeah, looking into the welfare of the people. As I said in my earlier talk, towards building a healthy nation. Yeah, thank you, Dr. Leong, is it, for the suggestion. We are aware of that, and we take note of that. With that, I think thank you so much for being with us. Please, yeah, look out for more talks from our fellows here at IPOM. Thank you. Assalamualaikum and have a nice day.